Good day. On behalf of the Tissue Viability Society and the sponsors of this webinar, Smith+Nephew, I'd like to welcome you to the second in our series of Stop the Pressure Ulcer Skin webinars. This and the others in the series will be available from the TVS website shortly following presentation. Our series is based on skin, S-K-I-N, the first being focused for S for skin assessment in those with darker skin tones, K for keep moving, where we shared best practice in caring for patients nursed prone, and tomorrow will be N for nutrition and hydration, where we will share work being done in that area. So please tune in for that. But today the focus is I for increased moisture. We are all aware that to prevent pressure ulcers, we must keep the skin clean and dry. So skincare is of the greatest importance. Now I'd like to introduce you to our two speakers today, Jackie Hughes and Gemma McGrath, who will be starting at our first. Thank you.
Thank you very much. So thank you, Tina, and thank you to everyone for attending today. I really hope you enjoy today's webinar on the importance of skincare as part of this fantastic week. In terms of objectives today, by the end of this webinar, you can expect to understand the importance of effective skincare, along with the properties and benefits that skincare products should have, and how using a simple skincare pathway can really help to enhance clinical practice. Next slide, please. So when we consider optimizing practice in skincare, we need to think about effective and efficient approaches where clinicians have access to appropriate skincare products, and then of course that these products are used appropriately and effectively in clinical practice. If you think of where your current service is in terms of effectiveness in practice, then it's important to recognise that there will always be opportunities to improve the current standard of skincare, no matter how good the current provision is. And the quality of care can always be enhanced, no matter where we work or, like I say, how good we feel that provision actually is. Consideration of skin frailty should be central to patient-centred care that considers the skin as a whole and considers risk factors that might be linked to the individual's overall health and well-being. A good starting point is to measure your current practice through the use of a skincare audit, for example, which as a benchmark can be used to measure clinical practice change against your usual standard of care. But really, if you don't know the extent of skincare practice in your area or whether this practice is effective, then you can't really begin to improve your own clinical practice. And just a word really, the improvements to practice do not have to be complex. I think we feel that any changes or any improvements are going to be quite time consuming or resource heavy. In terms of skincare, if you don't already have a pathway, it could be something as simple as adopting a new clinical pathway, which has the ability to really standardise care across your service and help drive down any variations in clinical practice. Next slide, please. So when considering the overall drive for effectiveness in clinical practice, the basics are all intertwined, as you can see on the slide. So through appropriate practice and appropriately used products comes an effective and efficient service, which will ultimately enhance the patient experience. Next slide, please. So how important is evidence-based practice in skincare? And I guess a lot of people sometimes feel that, is this really useful for something so simple as skincare? But really, if we look at evidence-based practice in nursing, that integration of research evidence, clinical expertise and patient preferences really help us, even with the most simple of nursing and guidance, into our problem-solving approach, encourages nurses to provide individualised patient care. And when we look at evidence-based practice, just as a bit of a recap, there's a variety of types of evidence that we draw on: randomized controlled trials, evidence gathered from cohort or case control analysis or observational studies, opinions from our clinical experts that are supported by experience, case studies or reports from committees, and of course, not forgetting the personal experience that needs to be recognised too as part of that process. So I'm sure we all agree that evidence-based practice in skincare is essential, just as it is in every other part of clinical practice. And the best practice guidance on care of the skin suggests that a full holistic skin assessment should be conducted at the first visit to that patient or on admission to hospital, depending the setting. An ongoing inspection of the skin should happen on a regular basis following a well-documented plan. This means that the clinicians can ensure any changes in the individual's health or skin status are identified and treated quickly. It's important to note that clear, consistent and accurate documentation is fundamental to a successful skincare plan. And the overall aim for any clinician is obviously to prevent that skin damage in any given clinical situation for the patients in their care. Next slide, please. So what do we mean by skin damage? So quite a few sort of definitions there you can see on the slide, but skin is at risk of damage from a variety of different factors, from dehydration to excess fluids to physical forces such as pressure. Older skin is also more prone to damage due to the aging process when several physiological changes happen. We know that skin changes can be related to the environment, the genetic makeup of the patient, nutritional status, and lots of other different factors. In aging skin in particular, that outer skin layer, so the epidermis, becomes thinner, even though the number of cell layers remains unchanged. Changes in the connective tissue also reduces the skin's strength and its elasticity. And as our skin becomes thinner and more fragile, this means that any rubbing or pulling on the skin can lead to skin tears. Also, as our skin ages, we may be less able to sense touch or pressure, vibration, heat and cold. And our blood vessels become more fragile and it can break, easily resulting in bruises. And we can get these black collections of blood, so purpura, and also the raised collections of blood, so hematomas, all of which can form even after the most minor of injuries. So it's so important that we particularly help our older patients with their skin being so fragile. Overall then, as we age, we are therefore at an increased risk for skin injury. And in terms of skin that is aging and skin repair once it's actually damaged, we know that aging skin repairs itself more slowly than younger skin. For wounds in particular, healing may be up to 4 times slower. And comorbidities such as diabetes, vascular disease, blood vessel changes, lowered immunity, and other factors also affect the rate of healing as we grow older. When the skin is exposed to excessive amounts of moisture, the skin softens, swells, and becomes wrinkled. All of these things mean that the skin is even more susceptible to damage. And moisture-associated skin damage, so MASD for short, occurs with or without erosion of the skin or secondary infection, and is characterized by inflammation. And to address the balance then for any skin at risk, we have some really simple tips in terms of being a clinician. You need to have that skincare regime consisting of cleansing, drying, and regular applying of effective skincare products. Next slide, please. So our skin is not only the biggest organ, but also the most prominent, and no other organ really represents us as much as our skin does. We like our skin to look nice. We might apply makeup to enhance how it looks. We might have a tattoo to complement our individuality. But there's no doubt that having healthy skin is absolutely vital to the well-being, both physically and psychologically, of an individual. And if we think of what the skin does for us physically, we know that a functioning skin barrier is needed to provide an effective barrier, regulates our body temperature, maintains moisture, and of course we need it for sensory function as well. So just a small recap then on the skin's barrier function, particularly as we're talking about skincare. The skin is composed of 5 layers, and the outer layer, the stratum corneum, providing the main barrier function for our skin. The barrier function of the epidermis helps to regulate passive water loss, which is known as the transepidermal water loss. A high transepidermal loss can exist when the skin barrier function is weakened. The barrier function of the skin should prevent excessive fluid gain or loss when it's functioning normally. But overhydration of the skin can cause disruption to its natural barrier and allows irritants to penetrate the epidermis. You can see from the diagram on screen that the pH of healthy skin is between 4 and 6, which provides an ideal acidic environment that supports the resident commensal bacteria on the surface of the skin. So those bacteria that helps the skin be more healthy, and they naturally occur on our skin anyway. Mature skin is far more susceptible to damage, as I've discussed previously, because of the aging process. Next slide, please. So moisture-associated skin damage then is an umbrella term for the 4 different types of MASD. It's defined as the inflammation and erosion of the skin caused by prolonged exposure to various sources of moisture that includes urine or feces, perspiration, wound, exudate, mucus or saliva. I think if you click on again, we should get some, that's it. So as I previously mentioned, it's generally accepted that we have these 4 distinct conditions, each having slightly different etiologies. And the 4 different conditions are classified as incontinence-associated dermatitis, intertriginous dermatitis, peri-wound moisture-associated dermatitis, and peristomal irritant contact dermatitis. So quite wordy in their sort of terminology. But it's really important that you can understand and distinguish between the conditions to ensure that you can provide appropriate prevention and management for your patients. And over the next few slides, we'll be focusing on the first 3 conditions that you can see on the slide there. Next slide, please. Thank you. So let's focus on the first type of MASD, so incontinence-associated dermatitis, or IAD for short. Most incontinent patients may well have had IAD at some stage or other, with varying severity. If you're a mum, you might have had a baby with nappy rash and problems with that, the baby's bottom in urine over a long period of time, but it's defined as erythema and inflammation of the skin caused by that prolonged contact with the skin of urine or feces. So that's the key thing here. It typically presents as inflammation of the skin surface, characterized by redness, and in some cases, swelling and blister formation. So exposure to the bacteria in urine or feces can result in some of the following symptoms. So burning and itching, redness, and that can range from a light pink to a very dark red, depending on skin tone. Patches of inflammation, like you can see on the slide there, or indeed a large continuous area of inflammation, so it can be quite extensive. Warm and firm skin, lesions, pain or tenderness. So all of these things can be experienced by our patients. The condition primarily affects the area around the genitals, the thighs and the abdomen. And IAD is caused by overhydration of the skin. So that's the key thing to remember, which really changes the pH level of the skin. When the skin then is exposed to that urine and feces, the pH changes and it causes an increase in skin permeability, which reduces the skin's natural barrier function. So if you remember from before, we talked about that natural barrier function and how essential it was. This is actually reducing that function. It makes it more prone to infection. And this also exposes the skin to additional threats such as friction or shear, which can result in further skin breakdown. Next slide, please. So let's now look at the second type of MASD, named Intertriginous dermatitis, or ITD for short, which is also, thankfully, as it's easier to say, more commonly known as intertrigo. The term simply means an area where 2 skin areas touch or rub together. And you can see an example of how this looks on the picture on the screen. So ITD is an inflammatory condition which occurs in skin folds caused or aggravated by heat, moisture, maceration, friction, and a general lack of air circulation. And when the sweat is not able to evaporate, the stratum corneum becomes overhydrated again and macerated, facilitating friction damage that is often mirrored on both sides of the skin fold. So if you think of patients where perhaps they might have had a bit of a tummy overhang, you can definitely see on both sides of that skin fold the friction and the damage that is caused by that sweat not being able to evaporate. This then in turn leads to inflammation of the skin, making the area again more prone to infection. And there are multiple factors that can impact on the development of ITD, and some of those are obesity, diabetes, urinary and fecal incontinence, poor hygiene, malnutrition, and individuals who are bedridden. So intertrigo is also frequently complicated by infection, and you often get that foul smell that accompanies this type of skin damage. And this is most common with the yeast infection Candida, although other bacteria, viral and fungal infections may also be present. So you can see how with a lot of this skin damage, things are perhaps not quite so simple as we initially thought. So that holistic assessment of the patient is absolutely key. Next slide, please. And the last type of MASD that I want to share with you today is peri-wound moisture-associated dermatitis. I'm sure you will have all seen quite a lot of this type of skin damage in your own clinical practice. And generally, this is caused by a wound that's producing high volumes of exudate. The production of exudate is a normal result of the inflammatory stage of wound healing. We know that. And over the past few decades, we've come to understand that moist wound healing is crucial to the best possible outcomes in wound care. But excessive amounts of wound exudate can really start to cause problems to the peri-wound skin. And we often say that this peri-wound area is in 4 centimeters of the wound edge, and it really becomes macerated and even starts to break down in some instances. Maceration is a term that simply means the softening and breaking down of skin resulting from prolonged exposure to moisture. This overhydration of the skin can then develop into maceration, and this can then be further compounded by incorrect dressing management and aggressive removal of dressings. Next slide, please. Thank you. I'm now going to hand over to my colleague Gemma, who will take you through the rest of the presentation.
Thank you, Jackie. Hello, everybody. I'm Gemma. For the next few slides, I'm going to be focusing on IAD, so Incontinence-associated dermatitis, and I will refer to that as IAD. And I'm going to be starting off with differentiating between IAD and pressure ulcers, because this can be extremely challenging. And when you have a patient in front of you, it can be really difficult at times. There's been many of times I've stood there, with a patient, with a colleague, assessing them and wondering, is this IAD or is this pressure? That said, it is essential that clinicians do assess accurately the cause of skin damage, allowing for a correct diagnosis, because the treatment of IAD and pressure ulcers are very different. For instance, to prevent pressure damage, the most important factor is to reduce or relieve pressure. And to prevent moisture damage, the most important factor is keeping that skin clean, dry, and well hydrated. However, there can be, for some, an overlap in treatment for patients. For example, IAD would not heal if treated purely by pressure ulcer prevention. But the presence of moisture damage may increase the patient's risk of pressure ulceration, so some pressure ulcer risk management may be required for that patient. So already you can see and understand why assessing the patient and identifying the correct diagnosis is so important. Next slide, please. Okay, so IAD and pressure ulcers have different etiologies. And even though the two can coexist, it's important to understand the difference to help us identify and correct cause of that injury. To help recognise the difference, I have this great image, which you can see on the screen. And I really, really like this because you can quite clearly see how IAD differs from a pressure ulcer. So on the left of the screen is IAD, and this is considered a top-down injury because the damage caused by IAD is initiated on the surface of the skin, and it then causes the skin to break down. Whereas with pressure ulcers, they develop below the wound surface. And depending on the category of the pressure ulcer, this could start at bone, muscle, or even the subcutaneous area. But because of this, it's therefore coined a bottom-up injury. Okay, so the damage starts below and it will work its way up. Next slide, please. When trying to differentiate between the two, there are a few different factors that you can take into consideration, such as history of the patient. To diagnose IAD, there should be a history of urine or fecal incontinence. Next is the symptoms a patient is presenting with. So although the patient could experience pain from both IAD and pressure ulcers, patients with IAD may suffer from discomfort, burning, itching, and tingling sensations from the area because the skin may be quite excoriated when the patient does have IAD. Next slide, please. The location can also tell you so much. Pressure ulcers tend to be over a bony prominence or associated with a medical device, and they are usually isolated to one area, whereas IAD can affect the skin on a larger scale, and it affects areas such as the perineum, the perigenital area, the buttocks, gluteal fold, upper thighs, and then this may extend over bony prominences. Next slide, please. Another factor to take into consideration would be the edges. So IAD will present as poorly defined areas, and it gives kind of a kissing effect on each side of the buttocks, or a mirror image, as Jackie has previously said. And you may find that the area could also be quite blotchy. Whereas pressure ulcers, they have very distinct edges and margins. Next slide, please. Then lastly, depth is another indicator. With pressure ulcers, the depth varies depending on the category of the pressure ulcer. So it could present as intact skin with non-blanchable erythema to full thickness skin loss, and the base of the wound may contain some non-viable tissue. Whereas with IAD, it would vary from intact skin with erythema, which could be blanchable, or non-blanchable. Obviously, if it was a pressure ulcer, it would be blanchable, and that's with or without superficial partial thickness skin loss. Next slide, please. Okay. Once you have carried out a patient assessment and IAD has been identified as the cause, a structured skincare regime should be implemented to help cleanse, protect, and restore the skin. Implementing an evidence-based skincare regime is a really important part of managing IAD, because without this, the skin will not be able to heal, and this can severely affect patients' quality of life. Therefore, using the right products to manage this is essential. The National Institute for Health and Clinical Excellence reviewed a lot of the evidence and concluded that the use of a foam cleanser together with a barrier protectant is more effective than soap and water. And soap and water is not recommended for cleansing a patient with urinary or fecal incontinence, as it is alkaline and it can upset the pH balance of the skin. Next slide, please. So now I'm just going to introduce to you our PROSHIELD skincare range. Next slide, please. The PROSHIELD skincare range consists of 2 products, which are the PROSHIELD Foam and Spray and the PROSHIELD Plus Skin Protector. Both of these are formulated for the prevention and management of IAD on both intact and injured skin. The PROSHIELD Foam and Spray Skin Cleanser is used to remove urine or feces from the skin, whilst the PROSHIELD Plus Skin Protectant protects that skin from injury and it restores moisture, and together they fulfill the aims of an evidence-based skincare regime to cleanse, protect and restore. A study by Warren Vernon in 2016 also found a 26% reduction in pressure ulcers and/or IAD following a 3-month evaluation of PROSHIELD skincare when it was used as part of a skincare regime and whilst following an education program. Next slide, please. So just delve into each of the products in a little bit more detail. PROSHIELD Foam and Spray Cleanser has been formulated to be pH balanced and therefore maintains skin pH during use. So the PROSHIELD spray itself, it has 2 spray modes, to which are the foam mode and the spray mode, hence the name. The foam mode is best for removing stubborn, hard to remove debris such as feces, whilst helping to eliminate odour, and it also prevents the need for any vigorous rubbing to the area on already vulnerable skin. And then the spray mode is used just to gently clean that affected area from urine and feces, and it is a no rinse formulation, which is considered best practice when managing incontinence, and it eliminates that need for any bowl washing. Next slide, please. Following skin cleansing, it's really important to protect the skin from further damage and restore it to a healthy, balanced condition where that injury has occurred. The PROSHIELD Plus Skin Protectant is a smooth, transparent, viscous, fragrance-free ointment that does not contain any of the common allergens, and its transparency is beneficial because it allows for skin observation and assessment once it's been applied. Not only that, I don't know if any of you have already used it and know the product, but you'll know when you squeeze this product from the tube, it does feel quite tacky, but that tacky formulation actually helps it adhere to moist skin so it doesn't run off. Another important consideration when selecting a skin protectant for patients with IAD is the effect that it may have on the absorbency of continence products such as pads. And the PROSHIELD Plus Skin Protectant is non-occlusive and therefore it does not affect any of the absorbency. Next slide, please. So now we just have a video to play, and this video is just going to explain to you how to apply the products.
PROSHIELD skincare range is formulated for the prevention and management of incontinence-associated dermatitis, IAD, on both intact and injured skin. The PROSHIELD skincare range cleanses and protects, helping to restore the barrier properties of the skin, helping to maintain skin integrity. The PROSHIELD skincare range consists of PROSHIELD Foam and Spray Incontinence Cleanser and PROSHIELD Plus Skin Protectant. The products are free from parabens, petrolatum, latex, mineral oil, lanolin and alcohol. PROSHIELD Foam and Spray is a gentle, pH-balanced, no-rinse moisturising cleanser designed to minimise the irritation of intact or injured skin in patients with incontinence. Select which mode you wish to use, either the foam or spray. Use the foam mode for difficult to cleanse areas and where you need it to stay in place whilst cleansing. The foam mode is particularly useful for breaking down dried feces and debris while helping to eliminate odour. For general skin cleansing, use the spray mode. To use the foam mode, turn the nozzle to the on position. Pull out the tip of the nozzle to allow it to foam, shake before use, then pull the lever in firmly. To use the spray mode, turn the nozzle to the on position and pull the lever firmly. Before using, prime the sprayer by squeezing the pump once or twice before initial use. Position the individual on their side and expose the area that needs cleansing, trying to keep them covered as much as possible for warmth and dignity. If there is a lot of liquid stool, try to isolate this with either the soiled brief or pad before cleansing. Make sure to remove all stool from the skin. If the affected area is severely damaged or quite wet, then gently wipe clean the excess moisture with a soft cloth or pad. Start by wearing gloves and selecting the correct mode. Start by cleansing the area with PROSHIELD Foam and Spray Incontinence Cleanser. Spray PROSHIELD Foam and Spray Cleanser directly onto the affected area. For any stubborn, hard to remove debris, use the foam mode and spray directly onto the patient. And leave on the area for 30 seconds to allow the cleanser to break down any hard to remove debris from the patient. Gently wipe clean and pat dry the area. And change gloves before applying PROSHIELD Plus Skin Protectant to avoid any contamination. The no-rinse formulation eliminates the need for a basin of water, rinsing and moisturizing. Cleansing and reapplication of the PROSHIELD system should be repeated as often as necessary and in line with your local protocols and guidelines. Do use PROSHIELD Foam and Spray Cleanser instead of soap and water for no-rinse, pH-balanced cleansing. Do use PROSHIELD Foam and Spray Cleanser to cleanse both intact and injured skin. Do use PROSHIELD Foam and Spray Cleanser to help break down dried stool. Do use PROSHIELD Foam and Spray Cleanser to remove PROSHIELD Plus Skin Protectant. Do use PROSHIELD Foam and Spray Cleanser to help eliminate odour. Do use PROSHIELD Foam and Spray Cleanser to help moisturize the skin. Do use the foam mode for difficult to cleanse areas as formulated to help stay in place while cleansing. Do not rinse off PROSHIELD Foam and Spray Cleanser or rub the skin, just dab dry and reapply the protective barrier. Do not use the same bottle on multiple patients. PROSHIELD Foam and Spray is single patient use. PROSHIELD Plus Skin Protectant is a smooth, viscous and fragrance-free moisture barrier protectant, which helps protect skin from incontinence-associated dermatitis and moisturizes and conditions the skin. Start by wearing a fresh pair of gloves. On application, the product may appear tacky to feel, but smooth in appearance. The tacky formulation can help it adhere to moist and dry skin. If using on intact skin for prevention and protection, then a thin layer is enough. A little goes a long way. Begin by gently smoothing PROSHIELD Plus Skin Protectant over the affected area. However, do not rub in as this may cause friction. When applying on injured skin, select the appropriate amount of PROSHIELD Plus Protectant to apply depending on the condition of the skin, in case a more generous amount is required. Gently smooth over the affected area, remembering not to rub against the skin. When applying over moisture on conditions such as severe incontinence-associated dermatitis, IAD, or moisture lesions, start from the intact skin and glide PROSHIELD Plus Protectant over the injured area to ensure all areas at risk of contamination are protected. The consistency of the product will change, but PROSHIELD Plus is still effective. PROSHIELD Plus Protectant is transparent for monitoring, but will leave a visible sheen on the surface of the skin and can be reapplied if no longer visible. Reapplication of PROSHIELD Plus Protectant should be repeated as often as necessary and in line with your local MASD protocol and guidelines. Dressings are not required as PROSHIELD Plus Protectant leaves a protective layer on the skin. PROSHIELD Plus Protectant can still be used when wearing incontinence garments or pads and doesn't clog pads when used sparingly. To remove PROSHIELD plus skin protectant, simply spray PROSHIELD foam and spray cleanser directly onto the affected area, then gently wipe.
For some reason, I did notice that it finished abruptly earlier. I thought it might have been my internet connection. Okay, if we can just stop that next slide, thank you. So sorry about that. There wasn't much left, just about 30 seconds, and it just continued to just explain how to remove that, and then just finishes off. So I hope that video was useful. It just kind of reinforces a lot of what I have already said. If you think that that video would be beneficial to your clinical practice for educational purposes, then do let us know, because we can absolutely share that. So next, I'm just going to introduce to you an example of an IAD management pathway that we have. Next slide, please. So this is the example of just one of our pathways that we have available for use. So pathways are a great resource as they help guide clinicians to best practice, quality care, and they also support with variations in care and help reduce cost. I really like this pathway because it's very visual and it's simple to use, and it uses a step up and step down approach. You can see from the pictures that it will help you identify the severity of the IAD, and it starts at the beginning with prevention, and prevention is key. So if your patient has healthy skin with exposure to urine or feces, then this pathway will guide you towards the use of a barrier cream, okay, such as Sorbiderm. So Sorbiderm barrier cream is a white concentrated cream which provides effective skin moisturising and long-term protection from bodily fluids on intact skin, okay. If your patient moves down, I'm working my way down them pictures. So if your patient has mild IAD with some erythema but no broken areas to the skin, then it's your clinical decision to either stick with the barrier cream, or at this point you could consider stepping up to a barrier film such as the Sorbiderm barrier film. So the Sorbiderm film is different to the cream. The film is a no sting barrier film that can be used on intact and damaged skin. So it's that step up. It forms a long lasting waterproof barrier and provides a protective interface between the skin and bodily fluids, therefore acting as a barrier against irritation. So next, for patients who are presenting with moderate IAD, which is erythema and less than 50% of broken skin, then again, it's your clinical decision to continue with the film or step up to the PROSHIELD skincare range, okay? And then for the severe category, which is erythema with more than 50% of broken skin, it is recommended that we do use the PROSHIELD skincare range. When using a pathway, it's really important to always reassess your patient. And if you find that the treatment you have initiated is working, you can use this pathway as a step down approach as well. Okay, so your patient may be on PROSHIELD, but when you go and reassess your patient, you do find that the health of their skin has improved. So you may want to step down to that Sorbiderm film product. You can also see that once you have decided which product to use, this pathway will guide the clinician on how to apply the product, which is obviously really, really helpful. But like I said, this is just an example of some of the pathways that we have available for you and for use. And if you would like more information on this, then please do let us know. Next slide. So lastly, I just wanted to share with you and present a case study that we have for PROSHIELD skincare. This case study is part of a case series and was written by Sister Sharon Moon, who wanted to demonstrate the effectiveness of the system on both superficial damage, so category 2, and moisture lesions within a 30-bedded integrated care system. Next slide, please. So this is the case study. So the patient was an 84-year-old lady with type 2 diabetes and chronic kidney disease, and she was admitted for rehabilitation following multiple falls. The patient was doubly incontinent, and on admission to the rehab centre, she was found to have a combined lesion. So she had a category 2 pressure ulcer and a moisture lesion on her inner right buttock. The pressure ulcer measured 1 by 1 centimetres, but there was extensive moisture damage to the surrounding skin, which you can see in photo 1. Following assessment, all the dressings were removed and the PROSHIELD system was applied. And this was carried out after every episode of incontinence. And this happened 3 to 4 times a day. Next slide, please. By day 4, the pressure ulcer had reduced in size to 0.5 centimetres by 0.4 centimetres, and the excoriation, which was a result of the moisture damage, had significantly reduced. By day 8, the pressure ulcer had completely healed and the moisture lesion had significantly reduced, and the patient continued to wear her incontinence pad along with using the PROSHIELD system to help maintain skin integrity. Next slide, please. So that just finishes this presentation. If you wouldn't mind, stop sharing, please. And I'm going to hand over to Tina.
Hello, everybody, and we're back again. Could I ask that if you have any questions, if you could please type those into the Q&A box or put those in the chat, and we'll go through those questions. But thank you so much, Gemma and Jackie, for your presentations. I do see we have a few questions for you here, and the first question is, are there any contraindications to PROSHIELD Plus, for example, fungal infections? Gemma, would that one be for you?
I can take that. Yep. So there are contraindications for the use of PROSHIELD. So for the PROSHIELD foam and spray, there isn't any listing as such on the IFU. However, for the PROSHIELD Plus, we do not recommend its use in, deep puncture wounds, infected wounds. So, wounds that you've mentioned there, lacerations, animal bites, or serious burns.
Thank you very much for that. I'm not quite sure how to pronounce his name, but Meritopi has asked whether patients should use both PROSHIELD products or just one of the two.
It is best to use them as a system. You'll get better outcomes, and it is, recommended best practice to use the foam and spray cleanser alongside the PROSHIELD Plus skin protectant.
Right. And another question from Meritopi was, do we use emollient alongside PROSHIELD?
It depends where you can, of course, use emollients where needed, but from an incontinence-associated dermatitis point of view, we would recommend that you do stick to just using the PROSHIELD foam and spray cleanser and the PROSHIELD Plus skin protectant. But obviously, if you're using a barrier film around the peri-wound skin, you would still need to use an emollient, for instance, for the leg, if you was dealing with an ulcer. Just an example there.
Okay, and actually, talking about the peri-wound skin here, the next question is, will dressings adhere to the PROSHIELD range?
Well, it's a difficult question, that one, because in an ideal world, where you're treating IAD, you wouldn't be managing them with dressings. Because like I said, with pressure ulcers and IAD, they are managed very differently. If it was just a pressure ulcer you was managing, you would manage this with dressings. But with IAD, you do have to have a good skincare regime, and we would recommend that dressings aren't used to manage this type of skin condition.
Thank you, Gemma. A question for you, Jackie. there are lots of pathways out there, and obviously Gemma shared a couple with us there, but after a period of time people seem to stop following those. Do you see any benefits of the use of pathways and how we could use them more in practice and keep them in use in practice?
Really good question, Tina. I think absolutely clinical pathways have a real place in clinical practice. I think as part of my role, I do a lot of work with clinicians and pathways, looking at their service in particular. I think part of the problem is with usage is that you need to know it's being effective. So I think the measuring, the validation of that pathway is key. So you may well start with quite a simple pathway. You would want to look at its use, audit, perhaps validate how it's actually been effective for your particular patient set. But then once you get that feedback from the initial validation process, does this pathway now need to change? And I know a lot of the pathways that are around for quite a long time are perhaps not updated as much as they should be, though often reflection changes in best practice. So absolutely, I'm a great advocate for pathways. I think the way that it standardizes care is great. It really takes away the variations in care. We want all our patients to receive the best care and the same type of care for a particular thing that you're treating them for. So yes, but for me, validation of those pathways feel as though clinically you're making a difference, and this pathway is really worth investing in because it's actually working for me. Mm-hmm. And here's my.
So would you recommend that people audit their pathways?
I think unless you audit, Tina, you really don't know. You don't know where you're starting from. You don't understand where your service is in terms of that particular care pathway that you want to look at, whether it could be a different areas of wound care, but having that understanding of the types of patients you care for, the comorbidities that they have, the service limitations that you might have, can all be teased out in an audit, which will then help you formulate the best possible pathway of care for your patients. And then it's an ongoing process, and then you could re-audit 3-6 months later, 12 months down the line, just to make sure it's still working for you. I think that is the crucial part of any kind of service improvement or clinical development. It is understanding your particular area in quite some detail.
Mm-hmm. Where do you think people might be able to go to for advice on undertaking that type of audit?
Okay, so sometimes some NHS establishments or healthcare providers do run their own audits. I know it can be a little bit hit and miss. Industry can certainly help you with that. From a Smith+Nephew point of view, we have a bespoke range of audits, from estate management to infection management to a full audit of wound care service. So use the resources are there. It's really just for your benefit to get that information and to so that you can see the solutions that you need to implement in clinical practice.
Thank you. Now, Nancy's asked a question which I think you may have sort of already answered, but would you recommend creating an individual pathway for each client or having a general one for the service?
Okay, so if we're looking at skincare, Nancy, and that's a great question, thank you. I think it's really important that we get that overarching service pathway so that each clinician that works as part of that service, they're all, working clinically to the same level and in the same direction for that patient. I think on an individual basis, it's doing that assessment of both the skin, the patient themselves, and really determining what individual things we then need to put in place. I think for an individual pathway, I would suggest that kind of sits within the individual sort of care treatment pathway where you would just outline the particular individual things you're doing for that pathway. But for the service as a whole, that one overarching umbrella pathway, and then taking that patient or client down the route, whichever is most appropriate for them.
Thank you very much. And now, does anyone have any other questions? If you'd like to type those quickly in the Q&A, or we'll be wrapping up fairly shortly. I'd just like to thank Gemma and Jackie for their presentation. Now, the TVS itself doesn't actually recommend any particular company's products, However, the Smith+Nephew range is one that you may want to consider. You can find out more information via our TVS website. You can link to the Smith+Nephew website. There's plenty of information there about this particular range of products. But as I say, we're not recommending any particular products there. Just as a reminder, certificates of attendance will be available from our website later this afternoon. This presentation, along with the others for our skincare week, will be on our website fairly shortly. So I'd like to particularly thank Gemma and Jackie for their presentation, and for those of you that have joined us, I'd like to say thank you for spending your time here with us today. So thank you very much.
Thank you, everybody.
Thank you. Thank you.
Goodbye.